Namaste and welcome to the Apollo families. Dear friends, a very warm welcome to all of you in this ongoing knowledge series of medication safety at Apollo. We all understand that unsafe medication practices and medication errors are a leading cause of avoidable harm in healthcare across the world. As per Institute of Medicine report, more than 1 lakh people die because of avoidable medical errors. The modern healthcare delivery has now become a complex healthcare delivery system and therefore become more susceptible to errors. This can result in severe patient harm, disability, and even death. It is in this context that medication safety has been selected as the theme for World Patient Safety Day 2022 with the slogan Medication Without Harm. Friends, we know that high alert medications have a higher chance to cause significant harm, adverse events, which can also lead to a sentinel event in patient care. All healthcare workers need to be highly vigilant when they deal with any such high alert drug. It is my privilege to share that today we have two experts who will share their thoughts on medication safety. I am just sharing my screen for today's opening presentation. I hope my slides are visible. So this knowledge series is in line with WHO Global Patient Safety Challenge, Medication Without Harm. So the topic for today is a hands-on approach to safety of high alert medications. With me, I have Dr. Sanjeev Sharma and Dr. Chirag Madan. Our first speaker would be Dr. Sanjeev Sharma. Dr. Sanjeev Sharma is a change-oriented healthcare leader and a leader mentor who works as Pharmacovigilance Center Coordinator, Member Secretary, Central Ethics Committee, Stem Cell Research at Indraprastha Apollo Hospital, Delhi, India. He actively promotes the importance of pharmacology and pharmacovigilance in the hospital system. Dr. Sanjeev Sharma's career includes various prestigious positions such as Assistant Professor Pharmacology and Medical Advisor ARI. He is a certified member of the Medication Safety Officer Society and a Six Sigma Green Belt. His qualifications include MD, MCP. And with the efforts of Dr. Sanjeev Sharma, Indraprastha Apollo Hospital is the first private hospital to go for pharmacovigilance program by Government of India. So it's my proud privilege to welcome him and hand over the session to Dr. Sanjeev Sharma.
Thank you so much, sir. First, Apollo Hospital giving me an opportunity to talk about high alert medications, and Satish sir for giving nice introductions about me. Coming back to today's topic, high alert medication and hands-on approach for their safety. High alert, your medication can't become without harm unless you deal with high alert medications. We are going to learn about concept of high alert medications, their characteristics, and how to make your own list of high alert medications, how we store them, how we label them, and what are those different strategies for safety of high alert medication. And then my colleague will deal with clinician's perspective of that. So coming back to high alert medications are those medications which have high percentage of errors and involved. Their error may or may not be more frequent, but whenever error happens in high alert medication, it is more serious, and they may lead to sentinel events, also causing increased patient suffering and of course increase additional patient cost. So if you see high alert medication in one line, they pose increased risk, causing significant harm if used in errors. So let us look into literature, what it says. Half of the preventable adverse drug event, opioid, insulins, and anticoagulant, these are the three drugs which may cause and which may lead to additional cost of 3.5 billion US dollars annually in extra medical cost. So let us look into how you can prepare your own list. You have to very good resources, Institute of Safe Medication Practice. Of course, you can look into your own adverse drug event data of your hospital from standard literature and WHO list. Looking into all this, you can combine your own list, and this list can be presented to DTC, and there, based on scope of services, we can discuss about this and make your own list of high alert medications. Before going into details, let us look into what are those contributing factors which may lead to the errors in high alert medications. Incomplete knowledge about drug names, inadequate drug informations, newly available products, similarly looking packaging and labeling of medication, and similar clinical use of medications. Of course, if you are not using computerized medication orders, illegible prescription and misunderstanding those verbal orders. Failure to follow your own SOPs and failures to perform proper prescription audit process. Coming back to general strategies, how we can improve safety of high alert medications. These are three primary principles for safety of high alert medication. Principle one is reduce or eliminate the possibility of errors. This should be done for maximum processes. If not possible, make that errors visible. Still, if it is there, minimize the consequences of these errors. All safety is based on these three principles. Let us look into what we can do. Implement a safety checklist. First, I told you, first we need to have list of high alert medications, then develop policies, how we are going to handle them, how we are going to store them, assess that, and make your own standard order set of all high alert medications. And any medication new you are going to add, look into whether this is high alert medication and evaluate the process of that. Simplify the process. I'll give you an example. If you have one step in a process, you have 1% chance of probability of errors in that process. If you have 25 steps in a process, your error probability increased to 22. If you have 100 steps in a process, your error probability is 63%. So how we can reduce these steps? Let's look into reduce the number of steps. One significant step which has come is computerized order entry, which has eliminated the transcription process. Unit dose dispensing. If you do that, chances of errors reduces. Dosing charts. Limited choice of concentration. If you have a drug in different concentration, you make it only limited one. Pre-mix solution wherever applicable, and do not eliminate crucial redundancies in the systems. Simplify and reduce number of options through standardization. What does it mean? We know heparin have different concentration. Use single concentration wherever possible. Standardize your all critical care drug infusion. Use them in all ICUs. Standard drug concentration and weight-based heparin protocol should be norm for this. Externalize or centralize error-prone processes for IV drug preparations. If you are using concentrated electrolytes, a good idea to mix them at the central place, if you are making your pediatric IV formulations, they should be always centralized. In India, we are lucky to have TPN mixed, which one comes from the manufacturers. If you are differentiate items that are similar but dangerous, if confused, like look alike drugs or sound alike drugs, we have to use Tolman lettering. And if they are two different brands, if you have a option, suppose your Normus line and Ringer lactate are same, buy Normus line from one manufacturers and Ringer lactate from other manufacturers, so that you can reduce the number of look alike and sound alike just for a few minutes. Okay. Differentiate items that are similar but then dangerous. One, I told you, if you are buying Normus line and Ringer lactate from same manufacturer, chances are they may be same. So buy from one, and Normus line from one manufacturer, Ringer lactate from other one, so that you can reduce the number of look-alike drugs in your hospitals. Other way is you use look-alike, sound-alike stickers, use big labels, and enhance with pens and markers to reduce them. Wherever possible, use barcode system. It is designed to avoid many errors. And if you have in computer systems drug which are sounding similar, coming one after the others, make sure that you develop in such a way that they do not come in drop down. If you have paper labels where drugs like carboplatin, cisplatin, blasphemine, Cristin are coming one after the other, make sure that they doesn't come in that particular order. We can also standardize our communications. Wherever verbal orders are followed, read back policies should be followed. If you are using smart pump, we have to standardize the dose of this drug. We should never use acronyms, apothecary system, and non-standard symbols in hospital, because they may play havoc, especially for high alert medication system. Independent double check is a good way of reducing the errors. Rather than double check, independent check, where two different persons verify independently the same thing and compare with each other. It is much better than double verifications, especially for high alert medications, as well as calculation of pediatric patient dosages. We have to use reminders for high alert medications like concentrated electrolyte dilute before use. And if you are using oral drugs, in a syringe for oral use only. We have to develop checklist and visual and audible alarms, so that we don't confuse with that. Of course, for lack of knowledge, improve access to information, give computerized drug information to all the stakeholders. Alert, if you are using computerized physician order entry, you can make it, we can attach it with drug information, and which gives automatic alert. Pharmacists should be present in those areas, and nurses and doctors should have access to them. And of course, internet access plays important role. Using constraints for limiting access to risky condition. Suppose you have concentrated electrolyte in your area. First, try to remove them from clinical area. If still there, keep them under double lock. This is a good strategy. If you are using neuromuscular blockers in your unit, make sure that you separate them from other medications and keep them in red color lidded container, so that everyone knows about that. Limiting drug use, one is whatever drug approval process is there, it is peer reviewed, discussed by different members of drugs and therapeutic committee, and you need to have a good credentialing process for using different types of drug. It means your chemotherapy drugs, only those people who have knowledge about using this drug, monitoring this drug, should use those drugs. If possible, use automatic stop order in your system, and if you are using computerized drug order entry, automatic reassessment of order should be done. And it is always better if you use drugs in your system for which have once or twice daily frequency. And you should have good system to change IV to oral, because chances with oral are lesser with compared to IV. Forcing function is very good guard for preventing errors. Enteral tube feeding without lure connection should not fix with your IV lines. Oral syringes should not be able to fit in your IV line. Pre-printed orders, they should have a limited number of medications and limited number of available doses with them. Safe procedures, very important. Implement them wherever possible, like IV infusion sets. If they are unprotected, there may be free flow of drugs, so automatic clamping of these drugs and dangerous orders, how we can prevent them, these processes should be there. Use of defaults, like if you are using patient control analgesia morphine, their concentration should be default in this. Once these drugs are given, patient monitoring system plays important role for high alert medications. It should be more frequent than other medication, and we should have a closer attention to vital signs, especially quality of respiration, neurological signs, and lab results. For all this high alert medication, we should have good monitoring system for all protocols and order set. Failure analysis of new product, whenever it is entering in your formulary, you need to do failure mode effect analysis and make sure that you check whether this is a high alert medication. If it is, and look into this. This is one. This is a high alert medication list of our organizations. We have clearly defined the groups, and for look-alike, sound-alike medication, why they are look-alike, sound-alike, and their generic name as well as indications. Coming to concentrated electrolytes, these are called killer medications in hospital. I told you, try to remove them from patient care area and mix them in a central place. And we need to have concentrate all this defined list, defined concentration in your hospital. This is high alert medication caution sticker, and when you mix this drug, we have a concentrated electrolyte after mixing this label. This is a BG slide. What it says that wherever you are giving this medication in hospital, you need to have standard concentration. You have standard protocol through central line, how much you will dilute, through peripheral line, how much dilute over how many hours you will give, and what is the maximum concentration per hour you can give. That is important for hospital to decide. This BG slide shows that what for concentrated electrolyte at prescription, what precaution you have to take, for storage, what precaution, and for preparation, administration, and what kind of monitoring is required, what kind of labeling is required. Prescription part, my colleague will deal with this. Storage, I told you, if you are storing, it's good to have in patient care area. First, try to remove it. If you are storing, store under double lock and care, and all the nurses in that area or all the healthcare giver doctors should be aware about these medications, and they should be double checked before they are prepared and admixed to the patient. Points to remember: we need to always double check before administering these medications. Monitoring is vital for these medications. Monitoring patient vitals is very important, and diluting concentrated electrolyte as per protocol is important. Narcotic drug is another high alert medications which have addicting potential. That's why it is a Schedule X drug. And all of you know that Form 3E as per government requirement has to be filled. We are supposed to maintain narcotic register in the pharmacy as well as at the level of wards and all. And all the unit people should be aware about dilution of narcotic drug. This should be standardized, and any unused medication should be discarded in presence of a witness. And problem comes with fentanyl patch. We have to apply a right date of applications and date of discard, and we need to have a good process of discarding these medications. And of course, monitoring parameters for this is paramount important. The common risk with narcotic drugs are, we have a drugs like morphine, hydromorphone. Luckily, hydromorphone doesn't have work in, it's not available in India, and leading zero may play important role. 0.8 versus 8 milligram of morphine may be fatal to the patient. Bolus doses, if you are giving bolus doses of these drugs, make sure that you put the maintenance dose, because there are different rates, concentration. That's why I was telling that we should have standardized concentration available, standardized protocol of these drugs in your hospital. Disposal of these drugs, very important, especially for transdermal patch. Common strategies: differentiate the product. Tolman lettering, if you are lookalike. We should know conversion table, especially for chronic opioid user patient. And if any intrathecal medication, of course, timeout should be followed for this. Education of staff for patient control analgesia is very, very important. We need to have a quick reference sheet for PCA, and all protocols should be followed. And of course, patient education plays important role. This busy slides again talk about what precaution, prescription level, storage, preparation, administration, monitoring, prescription. Again, my colleague will deal with that. Coming to another important killer medication is insulins. Very common error which happen with insulin is, we have two types of syringes, 100 unit and 40 unit, and we have 100 unit and 40 unit insulin available. If you use wrong syringe for the patient, wrong amount of insulin will go. Of course, lack of dose checking and wrong type of insulin is another area. For that, we have developed this insulin chart, which is available in all area, and all this insulin should be stored as per duration of action of this. So you need to have all the level: prescription, storage, preparation, administration, monitoring. All precautions, of course, should be available. Like, all the people should be knowledgeable about mechanism of action of insulins, information during regarding duration of action, fast acting, long acting, short acting, intermediate, biphasic, color coding of insulin as per duration of action, monitoring of blood sugar level pre and post administration. Any side effect of this drug should be monitored, and overview on optimization of therapy should be there. Next important high alert medication is chemotherapy drugs. It is not only toxic to the patient, it may be toxic to the handlers also, as per literature available. So whoever is doing admixture of this patient should be a personal protective equipment, and it should be done under laminar hood. Vincristine has caused errors when given intrathecal. To avoid that, it should never be dispensed in a syringe. It should be always dispensed in a syringe. Organizations who are dispensing it in 100 ml bag have reported no errors with vincristine. So that is fail-safe strategy which can be done. Always we have to check the body surface area every cycle for the patients. Updated lab information should be available so that proper dose can be decided. Patient caregivers should be educated about chemotherapy drugs. Effective communication plays important role. This is biosafety cabinet, and which should be cleaned every day. and do's and don'ts should be followed, and no food should be taken wherever you are mixing any eatables should not be there. And of course, disposal of hazardous waste plays an important role. This is a transport bag where all these chemotherapy drugs, which is a non-permeable and spill proof bag, and this is a chemotherapy drug high alert label. So, for making safety of chemotherapy medications, we should ensure calculation of dose is done every cycle based on body surface area. Information regarding chemo protocol, what is this protocol doctor is following, should be available to the pharmacist as well as nurses. Dilution under biosafety cabinet should be done. And it should be documented, and disposal of chemotherapy drug as per waste protocol of that particular area should be done. And monitoring also post chemotherapy drug is important. Again, this slide talks about safety at all different levels. This is how we store lookalike sound-alike drugs in different racks, far apart from each other, and different boxes writing indications, not only generic name, indication of these drugs, so that pharmacists are aware while dispensing, and we can avoid errors during this. This is an interesting case where 44-year-old male who had history of pulmonary embolism was put on warfarin, was admitted to the hospital for bilateral hydronephrosis with acute renal failure, for bilateral nephrostomy for tube placement. Post nephrostomy tube, the anticoagulation was resumed with enoxaparin 120 milligram twice daily in though patient have severely compromised renal function. Patient was transferred to ICU with clinical picture of shock. It was turned out to be hemorrhagic, had multi-organ failure, and of course patient passed away, and ultrasound showed intra-abdominal collection in this particular patient. So there is a definitely anticoagulant. It's this particular case shows the importance, and it shows that it can be lethal to the patient. Very, very important. And what went wrong? My colleague, Dr. Chirag, will discuss about this and how we can prevent this kind of cases. Anticoagulant like warfarin and acinocumarol storage is very important part, because dispensing errors may play havoc for this particular drugs. This is how typically they should be stored, and this is different anticoagulant, heparin, acinocumarol, and warfarin. And whenever patient get discharged, they should get a education, and of warfarin card is a good way of doing that. Common strategy is you standardize different concentration of this anticoagulant drugs. You provide anticoagulant services in your organization. You have standard protocols. You have a good medication, individual monitoring protocol for this. Medication reconciliation is very, very important for anticoagulant, which may lead to errors. In the last, I told you, if error happens, you have to minimize the consequences. How we can minimize the consequences of these drugs is by monitoring high alert medications. You need to have a good monitoring protocol for each and every drug. Like if you are giving insulin, your vital monitoring may not play important role. It is the blood sugar level and hypoglycemia monitor. But if you are giving narcotic or chemotherapy drugs, your vital monitoring is very, very important, baseline, and after 15 minutes it should be done. And according to the drug, we need to plan. Sometimes you are dealing with a cardiotoxic drug, we need to have a continuous ECG monitoring also there for that particular case. So different drug, different monitoring is very, very important. If you ask me one thing, which is very, very important, standardize your all the processes for high alert medications if you want to make them safe for the hospital. I thank you again for giving me this opportunity. Now I hand over to my colleague, Satish sir.
Thank you so much, Dr. Sanjeev, for this wonderful session. So friends, we have listened the deliberation on safety medications, and now I think these deliberations will help all of us as far as medication safety is concerned. So with me, we have our second speaker, Dr. Chirag Madan, who is an intensivist and a critical care specialist for neuro and stroke ICU in charge, Indraprastha Apollo Hospital, New Delhi. He is a AHA certified BLS and ACL instructor, managing critically ill patients for past 9 years. Also, he is a faculty of critical care course, MRCP course, and many other medical and academic courses. Dr. Chirag is exceptional, have an interest in teaching and sharing knowledge. And for that, he has his own medical channel on YouTube known as Intellect Medicos, which has over 15 million views. Also, he's an author of ECG Expert book and have many international publications added to his name. So it is again an honor to invite Dr. Chirag Madan, because he is a very busy clinician. So thank you, Dr. Chirag. Please take over the session.
Hi. Good evening. Good afternoon to all of you, and thank you so much for a very warm welcome. And today I'll just discuss about the clinician perspective of high alert medication. As already discussed by Dr. Sanjeev about a high alert medication, that these are the medication which can cause harm to a patient when used wrongly. And although the errors with these drugs may not be common, but the consequences of such errors can be devastating and can be very lethal to the patients. So obviously you need to know, first of all, what are the high alert medications and how to first prevent the errors. Then you have to make that errors visible to everyone, right? You don't need to hide those those errors. And thirdly, the most important for a clinician is, if at all that error has been caused, how to manage those complications, right? So the first and foremost, the medication which Dr. Sanjeev has already talked about is the insulin. We all know about the insulin, and we all use the insulin. Right. So what happens is whenever the insulin, the clinician is prescribing the insulin, the most common error is, first of all, the type of insulin which is being prescribed to the patient. So the person who is prescribing, also the person who is giving that drug, should know which type of insulin is it. Is it the short acting? Is it the rapidly acting? Is it the long acting? Right. And because there are some names which can be mixed. So look alike drugs or sound alike drugs. Like let's say you have a Novomix and Novorapid. So it sounds similar, but yes, the constituents are different. And that can cause harm to a patient if by mistake you have given the other drug. So the first and foremost thing I would like to say is you need to know the drug composition, which drug are you administering. Secondly, you need to know what is the route to be given. Because many a times we give subcutaneous with a sliding scale made. And sometimes whenever we are managing the patient in the ICU, then yes, with a very uncontrolled, or whenever the patient has a hemodynamic compromise, then we try to shift the patient from subcutaneous route to the IV route. So you need to know which route you have to give the insulin. Is it the subcut route or is it the IV route? And after that, you need to know the sliding scale. So it's not like if it is written as you have to give 20 units or 16 units or 8 units, you will keep on giving it. You need to know, you need to specifically see the blood sugar level of the patient. right? And also before giving, you need to know whether the patient is actually having the food either orally or maybe from the RT feed, right? If at all the clinician has stopped, the RT feed because of unknown reason, then yes, the dosage is different. I mean, you need to either stop the insulin or you need to decrease the insulin, right? So this is very important. You have to again see the drug chart and see the patient condition also whenever you are about to administer insulin to the patient. And thirdly, as this is mentioned, the omission of insulin due to lack of communication or incomplete handover by the staff. So sometimes what happens is you don't write in the handovers, and sometimes the insulin is omitted, right? And this can be very harmful for the patient and even can be deleterious or lethal for the patient, right? So you need to know what the patient is on, how much is the frequency, and how much is the amount you need to deliver. Now, the another important aspect of insulin is how much the quantity or how much amount of insulin to give. So let's say you have to give 15 units. So if at all the clinician, they say a verbal order to the staff that give 15 units, the first mistake can be that 15 can sound like 50. So to prevent that, you need to have a written order. 1-5, or just if you are spelling it, then you have to spell also 1-5 units. The other mistake or the other error can be that whenever you are writing, a clinician is writing on the drug chart, then you can write that sometimes it happens is 2U. U is for the units. And many times I have seen in our in the hospital settings that U is taken as 0, and that looks like 20. So insulin 20 units, and if you have to give 2 units, that can be very, very, very lethal for the patient, right? Patient can directly land into hypoglycemic episode, and that can even, this much of hypoglycemia can even cause cardiac arrest to the patient. So always listen what is said, and the best is always to have a written, not a verbal, a written order, and that to avoid writing U for the unit, just write full units. 15 units or 2 units, right? So this is the most common error which I have seen. And obviously then how to, first of all, this is to prevent. Now, if at all your error has occurred, let's say by mistake, you have given a high dose of insulin, then as a clinician, you need to know how to manage that. So for hypoglycemic episode, you need to be having in your store or in your area where you are working as a dextrose containing fluids, mainly the 25% dextrose or the 50% dextrose. And whenever this error has happened, you need to highlight that. You need to make it visible also so that it doesn't happen again, right? And then coming on to the next point, obviously we have talked about the wrong frequency ordered leading to delay in administration. So your frequency should be mentioned properly. Then many times in cases, whenever the patient is admitted to your hospital, either in your ward or ICUs or emergencies, what happens is the patient was previously on insulin, and you sometimes omit, you tend to forget, or you don't take the history of having an insulin. Then that patient is without the insulin, and this is very lethal typically when I talk about type 1 diabetes patient, and they can directly land into DKA, that is diabetic ketoacidosis, right? And so this is a very harmful and very lethal situation. So always take a good history, and you need to prescribe that. Again, if there is a history that patient was on insulin, then yes, you have to continue that. And secondly, whenever you are you have a patient and patient is fasting, you have kept NPO for any reason, let's say patient has to undergo any kind of surgery or any kind of procedure, then yes, you need to decrease the dose, or even you need to omit, right? And ordering the wrong type of insulin due to lack of knowledge of various insulin types, which we just discussed. So this is very important. First of all, I'll just summarize again for the insulin, because this is very important, is to write down the written order should be there of the insulin, which type is it, how much is the frequency, what is the dose, right? The dose, that too in units, you have to write units. after that. And then, yeah, by the way, let's say you have that complication happen, you have those errors made, then yes, you need to know how to manage that also. Then the other high alert medication I would like to emphasize on is anticoagulants. And mainly the anticoagulants are either the warfarins or the heparins or the oral anticoagulants, right? So many times the problem with the anticoagulants is if you give high dose, obviously that can cause bleeding in a patient. And bleeding can be very lethal. It can be, the bleeding can be in the brain, it can be in the GI or any other region, which can obviously cause a hypovolemic shock to the patient, right? So you need to know what anticoagulant you are prescribing and what is the dose of it. So if I talk about the warfarin, obviously you need to know the interactions along with the other drugs. So you need to go, you have to see the other drugs which you are administering to the patient, because many a times it is interacting with the other drugs. So either you can call the pharmacist in your area, or you just see the drug interaction of the warfarin with the other drugs which you are giving to the patient, right? And many times what happens is you need a dose adjustments, right? If you giving the oral anticoagulants, or let's say you are giving the heparins, the low molecular weight heparins, and you don't know that, yes, previously the renal function of the patient was good, but now the AKI or the acute kidney injury has set in. So then you need to decrease the dose and you need to modify the dose according to the renal parameters, right? So you need to calculate the creatinine clearance, and it is very well given in on your Google, or there are many apps of it. So you just enter the variables on that, and you need to know how much is the creatinine clearance, and then you need to modify the dose accordingly. Because if you don't modify, then yes, the concentration of that particular anticoagulant will be on a higher side. Now, again, the important is the clinician perspective in case the error has happened. So for that, obviously, if you have your warfarin, right? And many times we have warfarin, and by mistake, the staff has given a high dose. You have not seen the urea or the creatinine of the patient, and you have given a warfarin or the DOACs, the high dose of it. Now you need to know how to treat it, how to prevent that complication. So first and foremost, you need to check, and you need to have an eye over the status of the patient, the hemodynamics of the patient, the clinical status of the patient, right? And then how to revert it. So for reversal of warfarin, typically, if I talk about, obviously, it is the vitamin K, because you need to reverse that. Okay. And secondly, you need to have that PCC, prothrombin complex, or if not available in your hospital, then yes, you need to go with FFPs if at all the patient is bleeding. So you need to have an eye over the monitor and also the clinical status of the patient. Then talking about the third, which is the opioids. And very commonly we use opioids in our ICUs and in the patients on end of life care. In the normal scenarios, I mean, in the majority of the hospitals, they go with the opioid most commonly used is the fentanyl. So whenever you give a high dose of it, obviously opioids have a sedative effect. And if you give a high dose, that can cause respiratory depression, causing CO2 accumulation in the body. And yes, the patient can become drowsy, and even the state can happen that, yeah, you need to intubate the patient. So this is again a very high alert medication. You need to know about the medication which you are giving to the patient, which you are prescribing, and also the dosage. So the dosage, if I talk about, let's say you have given, so I have seen one of the error that fentanyl was being given to the patient, and the clinicians just said it was just a verbal order to give 30 micrograms of fentanyl. But because it was a verbal order, the staff heard as 30 ml. So this was actually very lethal, right? So 30 ml, that means 300 micrograms. So patient was given that much of drug, and this is very lethal for the patient, right? But yes, we were all standing over there. That not happened, but yeah, that could happen. That can be the complication, and patient can land into serious complications. So important again is the verbal. So you don't go with the verbal orders, you need to write it. That is for the prevention. And also you need to know the dose of it and how to titrate the dose, right? You need to know the titration, how you are making that, because the 1 ml of fentanyl, which we normally dilute or which we make, is having a 10 micrograms of fentanyl. So you need to know about the drugs which you are prescribing. And yes, again, if at all, now again the other point of view, because now you are giving this medication, you need to know what are the complications and how to manage. Let's say your staff has given a high dose of fentanyl, then yes, obviously you will have a look on the patient, the general condition of the patient, and also the conscious level, so that patient doesn't become drowsy. And also you will be having an eye over the respiratory rate of the patient, right? So you need to manage the complication. You need to know how to manage the complication as well. Now, the last two medications which are the high alert are the concentrated electrolytes, in which commonly which we use is the IV KCl, potassium chloride. And yes, it is a high alert medication, because if you give a high dose of it, that can cause serious arrhythmias in the patient, and patient can land into a cardiac arrest. So you need to know again how you are making the drug, how much to give, and also you need to monitor the potassium levels accordingly. It's not like you have just started IV KCl and you continue till the next morning. You need to monitor depending on the condition of the patient, the urine output and the other parameters. You need to monitor the potassium levels again, either 8th hourly or 12th hourly. So you need to titrate the electrolytes of the patient. Also, the other concentrated electrolytes, as rightly mentioned by Dr. Sanjeev, is your 3% normal saline. So how much is the dose you are giving, how much correction of sodium you like to expect. So these are the other things which you need to know whenever you are prescribing these medications. And the last high alert medication, which I'll talk about, is just a basic about a chemotherapeutic agents, which Dr. Sanjeev has already discussed about. The most commonly given is the methotrexate. And very commonly, the dose is you prescribe once weekly. And many a times there can be an issue that drug is given on a daily basis. And again, that is again a lethal complication. So my main aim for this talk is about, first of all, you need to prevent the errors. Secondly, if at all it has happened, you need to make it visible for others, right? For that it doesn't happen again. And secondly, you need to know what can be the complication. So you make it visible. And thirdly, whenever you are administering these kind of drugs, high alert medication, you need to know how to manage the complication. First of all, what is the complication, what can be the complication, and how to manage those complications. So this is about the high alert medication. And so thank you so much for listening to this video, to this talk. And thank you for giving me the opportunity to talk about this high alert medication. Thank you.
Thank you so much, Dr. Chirag. It was a really wonderful and eye-opener session for, I hope, for everybody. And thank you for your time and giving us your clinical perspective to all of us, so that we come to know that how clinician, prescribe, monitor, and in case any medication happen, how they, treat and manage the harm caused, if any. So thank you once again. So friends, in our web chat, we got one question which I would like that Dr. Sanjeev Sharma to address. Dr. Sanjeev, the question is, generally in critical care areas, we have one medicine trolley without lock and key. Kindly suggest about process improvement for storage of high-risk medication.
Thank you so much for this. In ICU, and of course, you'll be dealing with one of the very killer medication is neuromuscular blocker. And if you have only one trolley, make sure that you store these medications away from other medications. And in red color, leaded containers separately from other medication. That's one strategy you can do. Second is you remove your concentrated electrolyte from such ICUs. Make sure that it is only available in pharmacy, and if possible, it is mixed there and comes to your ICU in that way. So from those two killer medications, you'll get away and you can manage very well. Third important thing is your narcotic drugs. As how narcotic drug as per law has to be under double lock in that particular area, so that double lock is required for this. That's how we can handle. And of course, you need to have standard order set for all high alert medications in your ICU. If for concentrated electrolyte, how much you are giving through peripheral line, central line, how many milliequivalent per hours you have to give, of course, and how much correction and lab value, how frequently lab has to be done for that, and monitoring is important. These are different steps where we can handle all this high alert medication in such scenarios.
Thank you, Dr. Sanjeev, for your valuable inputs. So friends, with this, we are coming to the near end of this session. But before that, I really thank both my speakers. Thank you, Dr. Sanjeev and Dr. Chirag, and all our participants who have spent their valuable time. So before we move on, I would like to remind all of you that in the ongoing medication safety knowledge series, tomorrow we have a very important topic as antimicrobial stewardship program, practical tools to ensure patient safety. That is on 14 September, Wednesday, same time, 3 to 4 p.m. We have we will be having moderators as Ms. Pritindra Sachdeva, and speakers would be Dr. Dhanya and Dr. Narendra Patil. Please do join, and it is requested that please register yourself separately because the previous link will not work. You need to register yourself separately for each day sessions. Please stay tuned for this upcoming knowledge program. All participants who are attending our webinar series for all the 6 days may stand a chance to win a lucky draw. And we shall get in touch with all the winners very shortly. Please note that we will be, giving the digital certificates to all the attendees for all the webinars. Our upcoming 9th International Patient Safety Conference, it will be held in Delhi on 1st and 2nd February 2023, that is next year, for which the pre-registrations are open. You may please check the details on the given site, website, or send in your queries at the given email ID or call on to the given numbers. We request you to get the early bird registration done for the conference, as it includes discounted conference fees and other exciting features. In addition, we also request you that Apollo has made a patient safety club, which is a niche initiative and has been constituted with the aim of sharing knowledge and many such programs. The aim is to have a collective wisdom, share good practices, and so that we all can contribute towards patient safety and good clinical outcomes. We urge you to join our patient safety club. Please write to us with your interest, and our team members shall get in touch with you. Thank you so much for your active participation and patient hearing. It was a wonderful interaction with all of you. Thank you so much. Have a good day. Please do join tomorrow. Register yourself and please give your feedback so that we can improve whatever lacunas we have in our ongoing program. We can improve because quality is always a journey. It's not a destination. Namaste. Wish you a very good luck. Thank you so much.